Hello and welcome everyone. My name is Albie Salvatore. I am a VP of Partnerships here at Cedar. I want to thank you all for joining us for today's healthcare panel with Dan Nigrin, MD, Chief Information Officer of MaineHealth, and Sharlene Seidman, the Vice President of Patient Financial Services for Yale New Haven Health. Today's virtual event will wrap up in about an hour. Our speakers can't see or hear the audience, but please feel free to use the chat function in the Stage tab to post any questions or comments, and we'll plan to save some time for a few audience questions at the end of the conversation. Before we get started, a couple of quick plugs. If you like today's event and you want more, you can sign up for our mailing list on the events page of our Cedar's website. And our next Cedar Talk is coming up on October 6th with John Collison, the president and co-founder of Stripe. Now I'd like to introduce this afternoon's participants and our moderator. Moderating the panel today is our very own Seth Cohen, Cedar's president. And for the panelists, first off, we have Daniel Nigrin. He's our Chief Information Officer at MaineHealth. Dan previously served as the SVP and CIO and practicing pediatric endocrinologist at Boston Children's Hospital, where he also was an assistant professor of pediatrics at Harvard Medical School. As a healthcare CIO for over 2 decades, Dan has been responsible for all IT systems at both of these large multi-billion-dollar provider organizations. This experience has put Dan in a very unique position to put in practice cutting-edge digital technologies and ideas, bringing advances to patient care, quality, and research, but while keeping in mind the needs of busy clinicians. Next up, we have Sharlene Seidman, Vice President of Patient Financial Services for Yale New Haven Health. Sharlene joined the health system in December 2010 as the Director of Revenue Cycle IT Systems. She was responsible for implementing and leveraging the Epic software applications that support the strategic and daily aims of Yale New Haven Health and Yale Medicine as they relate to patient scheduling, registration, admissions, authorizations, bed management, transport, environmental services, clinical research, and hospital professional billing. In 2014, Sharlene was promoted to Executive Director of Corporate Business Services. Prior to joining Yale New Haven Health, Sharlene was employed by Yale Medicine for about 13 years as the Director of Information Systems and Decision Support, and for 5 years by the UConn Health Center in Farmington, Connecticut. So I want to welcome you both. Thank you for joining us and sharing your experiences today. And I'm going to pass it over to Seth to get us started.
Awesome. Thank you, Albie. And thank you, Sharlene and Dan, for joining us this afternoon on the East Coast, morning where I am and here in San Francisco. So I'm really excited to kick this off. And I also want to encourage folks in the audience to post questions as we go, because we would love to hear from you and what's on top of mind for you all. But let's kick things off by talking about how consumer expectations are influencing healthcare. As we all know, in e-commerce, the mindset is so prevalent that we need to be a digital-first organization, engage with consumers digitally. To what extent are you thinking about digital connectivity options for your consumers, for your patients? Are these utility plays or are these really strategic avenues for you? Dan, you want to start?
Sure. Thanks.
Sorry, I should have been clearer on that.
Yeah. And thanks, Albie, for the intro as well. So yes, this is absolutely table stakes, frankly, in our view these days. Consumers' expectations are, sky high when it comes to digitally enabling things, facilitating their interactions with the healthcare environment. And so we absolutely think that these are requirements of us at this point and no longer an optional thing for us to provide. Sure, there are utilities as well, and as I said, I think they are going to be requirements. But at the same time, I absolutely think that they can be strategic enablers as well. And we'll probably talk over the course of the hour about some ways that we're envisioning that. But I really do see them as sort of leading edge ways that we can start to rethink how healthcare is provided. And COVID certainly has helped to accelerate some of that thinking. I know we'll talk about that as well. Yeah. But absolutely, we see these things as invaluable new approaches to how we do things. And for organizations that are not yet thinking along these lines, I think you better hurry up, because it's all coming at us quickly, and expectations are high.
Yeah. And I can echo what Dan commented on, use the word requirement. We started our digital journey about 5 years ago, but we've really accelerated what we've been working on because it has been a requirement. It's no longer a nice thing to have, a nice offering for our patients. A digital experience has been really part of our value that we're creating for our patients, because we're finding that a lot of people don't necessarily want to call on the phone or speak to someone live. The digital experience is what people are craving. And I think that really became inflated with companies like Amazon that created a really easy digital experience to get something accomplished. So we're in the same place.
Yeah. Consumers use Amazon and then they show up at our healthcare systems, and their experience at Amazon is what they then expect everywhere else. They're not different consumers.
I curse Amazon every time they come out with a new feature because it's something I've got to keep up with now.
As a health system leader, you mean?
Exactly.
Yeah. And I know we're eager to get into some examples of what you're doing to employ these digital assets strategically. But as we do, actually, maybe Charlene, this is a good transition to some of your work. So Yale is, I think, the biggest health system in Connecticut. You also operate in New York and Rhode Island, if I stand correct. And so when you think about the scale of your system, how are you using some of these digital assets, especially with respect to the patient financial experience? I know in prior conversations you've referenced QR codes, but what's top of mind for you?
Yeah. So my area of responsibility is revenue cycle, and that means often the first interaction and the last interaction. So for those patients who want to reach out to us and schedule an appointment, or we need to talk about authorizations, that's the access side of things. And then on the back end, we have bill pay. And if a patient receives a bill, they want to pay their bill, or they want to find out what kind of options do I have to discount my care, or potentially even do I qualify for free care, free financial assistance through your organization. And so we've really been focused the last several years on consolidating our bills. You mentioned we're a large organization. That creates complexity. It creates complexity for our patients and understanding who's who. Why am I getting separate bills for one encounter that I had within your health system? So it's confusing. So we've been focused on not only the front end experience, but also the back end. And you mentioned the QR code. So it's an easy way. I don't have to look for a link out to pay my bill through a portal. I can just scan that QR code, and now we're all using it at restaurants. To pull up a menu. So patients are starting to understand what it is too.
So are you seeing uptake? I mean, I had never used the QR code. Embarrassingly, I work in technology. I've never used the QR code before COVID and the menu situation. So are you also seeing an uptick in utilization of these codes?
We have. And, so it's not that our patients want a 100% digital experience all the time. People like to keep a paper copy, especially of their bills and things that they pay. But you can very easily bring that bill on your way to wait at that restaurant. You can scan your QR code and pay it while you're waiting.
Yeah.
That's what's happening.
That's great. And so Dan, you are a physician executive, and I know you joined MaineHealth last October, I believe. That was last fall, so during the pandemic. And so, would love to get to a couple examples of how you're employing digital assets strategically. But maybe first, just tell us, what is it like joining a health system in the middle of a global health pandemic?
Yeah, Seth, I thought I had this perfectly timed. So October was when it was announced. And so decision making, for me came around the September timeframe. And if you remember back to, around this time last year, we were sort of in a little bit of a lull. Things were a bit quieter, and certainly before the explosion that hit us in the beginning of calendar 21. So what I thought was the perfect time for me to do my move ended up being exactly the wrong time. Wrong maybe in quotes around it, because one thing that I will say was the silver lining is that getting thrown into the deep end of the pool in terms of learning a new organization and working collaboratively with my team on getting things done was certainly a way to accelerate that process, and I needed to learn quickly. So I view that as sort of the silver lining of having joined the organization at a period of real heightened activity. So we certainly needed to do a lot very quickly, like all organizations, especially ones setting up mass immunization programs for their patients and members of the community. That's something that we too set up at MaineHealth. MaineHealth actually ended up being one of the largest providers of immunization in the entire state of Maine. The state relied heavily on its health system infrastructure to get the vaccines in arms. And so I think it still holds true today. But at the time, we had given approximately a third of the entire immunizations in the state of Maine and eastern New Hampshire. So we definitely needed to mobilize quickly. We set up mass immunization sites. We used this old horse racing track that was closed a few years ago, but ended up being a perfect place to hold a mass immunization clinic like that. And so we needed to set up a whole lot of infrastructure and mobilize a lot of technology to make that happen. So that's certainly something that we did in a rush. But you mentioned the experience that I've got with my clinical hat on, and that definitely did help me as well, because I understood both with my experience at Boston Children's in sort of the first phases of the pandemic, but all along the way, what some of the strains that our clinicians were going through, what some of the technical challenges were. Initially we were working through things like PPE shortages and how we facilitate technology-based interactions with patients in hospital rooms or exam rooms that could result in fewer, entrances into the room and preservation of the PPE. But also things like, how do you enable virtual rounding? Again, when we were unsure what the scenario was around how safe it was for folks to be in the hospital setting, we wanted to minimize their interactions. And so using video to enable, rounding teams of clinicians to be able to do their work effectively while maintaining their distance and so on. So that was definitely another set of lessons learned. And then finally, one of the things that remains with us now and that we're still dealing with is just the mental strain. And burnout's the wrong word, but it's along those lines. And whereas before we thought that maybe this was something that we were going to get a handle on quickly once the immunizations were made available. Clearly, we've seen that that's not the case because of not full immunization of our populations, as well as the emergence of these new variants. And so I think the learning that we've taken away is that this is something that we need to be ready for over a long haul, and we need to make sure that we're giving our providers the respite that they need and supporting them in their experiences as well, because this hasn't been easy for anyone on the care delivery side of things.
Oh yeah, I can imagine. In fact, I talked to some hospital leaders who believe that there's going to be a wave, sadly, of behavioral health challenges and trauma that will emerge only once people have the space to even process what's been happening inside the hospital walls.
Absolutely. Mental health has and remains a big challenge for us. But again, one actually that we found that technology has helped to facilitate.
That's wonderful. Well, and I imagine it's your experiences being on both sides here, a physician and an administrator, that gives you kind of that credibility to bring those things in-house.
Yeah, absolutely.
Yeah. And, just to speak to that a little bit more, the mental health needs of our communities and our country really has grown so much. And I don't think this is regionalized, and telehealth through that digital experience for mental health our largest user, those patients who've required some kind of either group therapies or through our mental health services has been the highest volume.
Oh, that's interesting. Of all telehealth cases, that category is the most prevalent. Very interesting.
Yeah. That's the same for us as well, Seth. In virtually every care delivery subspecialty or in primary care, clearly after the initial pandemic surge where we were seeing, 70, 80, 90% of our ambulatory visits conducted via telemedicine, that came down quite a bit as things stabilized. But the one place where it's still at that very high level remains in mental health.
Wow.
True for us.
So speaking of some of these public health challenges, let's talk a little bit about equity and the servicing of lower income populations, which we all know have been disproportionately impacted by COVID. As we think about modernizing the system and the ubiquity of digital technologies, we need to think about how do we make sure our technology solutions work for all patient populations and make sure no one gets left behind. I know, Dan, seniors in Maine, live in poverty at higher rates than the national average. I'm sure this is something that you think quite a bit about. What are some ways that MaineHealth is working to reach those populations that may be relatively less accessible?
Yeah, thanks, Seth. You're right in that we do face a particular challenge in Maine. We are, quote, the oldest state in the nation in terms of average age of our population. So there's that challenge with respect to utilization of technology, as well as the fact that we do have a high rate of people who are living at poverty or below levels. And third, that it's a very rural state where, frankly, there's lack of penetrance of broadband internet or even cellular phone service in some places. So the first thing we do is basically try and listen to our patient populations. We've got good geographic coverage for the areas that we've got a presence in, and so we have patient advisory groups that convene and give us direct feedback around what their needs are, where what we're providing is not meeting their expectations or what they're able to absorb. One thing I will say that we were a bit surprised about with respect to our older population and things like virtual visits and telehealth is that actually their satisfaction in those services for those people that have utilized them remains very high. In fact, it's almost as high as the younger populations as well. So for those individuals who got the technology and got the access to it, we're very happy to find that in general they're very pleased with the service. Yeah. But no doubt there's definitely instances where they're not able to access those services. So what we do is partner with a number of organizations. So in particular, there's a national center called the National Digital Equity Center, which happens to be based in Maine.
Great.
And they provide no or low cost devices to community members that have expressed a need for them. And in addition, they have a digital literacy program where they educate folks who've not had as much experience with using these tools and technologies and getting them up to speed. In addition, some people may not know that the FCC has made a broadband subsidy program available during the time of the pandemic. So they help to subsidize the cost of internet connectivity, and that's very much helped in several of our territories and with our patient populations as well. So basically, we try and give as much support as we can using the technologies that we've got, recognizing that it's not always going to be met with a person on the other end that knows how to use those technologies. And we essentially point them to services that have been made available to them to help get them up to speed and to assist them. But the last thing that I'll mention is we utilize resources, things like Aunt Bertha, which are national repositories of community-based resources that are meant to help people with a variety of different needs that are going to be based on social determinants and things like that. And so we also additionally point people to those.
Wonderful. It's impressive to hear the scope of the different partnerships, public-private partnerships, local, national, that you're exploring. And you mentioned one thing interesting before we turn it to you, Sharlene, that we found as well, which you noted that it can be difficult to engage someone in some of these digital initiatives, but once you do, you end up, sustaining that engagement. And that's what we found too, is that once you introduce a more convenient, more accessible, modern approach, no one says, well, no, I'd like to go back to the old way where I couldn't find the person I was looking for and I had to sit on hold for 17 minutes. That was better. Once you're able to demonstrate the value of that experience, it's almost an annuity of sorts where you continue to realize the benefit of that.
Yeah, you're absolutely right, Seth. In fact, look, these technologies are not new for the pandemic. we had these, and
Right.
and we were having to beg and cajole people to use them
Right.
before. And in fact, both on the clinician side as well as the patient side, I have lots of examples of absolute naysayers. No way, my patients are too complicated. We could never utilize something like this. And same from the patient side of things as well. And for sure, you know, as you said, after everyone was forced into it during COVID, all of a sudden, those people that were naysayers now are sort of saying, you know what, that wasn't so bad. I got quite a lot accomplished that I wouldn't have otherwise been able to. Maybe there is a place for this.
Wonderful.
You really only have one chance, though, so you have to make it easy from the beginning. Otherwise, someone will try it, and if it's not easy, they may abandon it and then say, "Oh, I've tried that in the past. It's not going to work. It's too cumbersome, too difficult."
Well, and Charlene, you know, maybe elaborate a little bit more, because you have an interesting dynamic in that you serve some of the wealthiest districts in Connecticut, you know, like Westport and Greenwich, but you also serve more impoverished areas as well, like New Haven and Bridgeport, Waterbury. So how do you think about this question? Maybe give us some examples of what you've worked on here.
Yeah, so you're exactly right, Seth, that Connecticut definitely has some of the highest and lowest income areas. So we've done a lot of work around the digital experience and making the adoption of it somewhat easy for our patients. So one example that comes to mind is telehealth. So with COVID, we started seeing a pop in the number of patients who were using telehealth for visits. But what we found out was that we didn't have a high rate of patients who had an online portal, knew how to use the system. So what was happening was that the appointment time would come up and then we'd see a delay because they were trying to connect. Their internet wasn't working. They weren't sure how to get into the system. And so we were seeing where we had people waiting in a waiting room before. Now it was the same, but through a digital experience. So what we quickly created was a telehealth assistance group. And we had a group of people who would call patients before the appointment and walk them through. Do you know how to download the app on your phone? Let me help you with that. Let's test it out. And so they would create little fake visits. And we found that some people were really quick, really easy. Nope, I got it myself. I don't need your help at all. And some people, it could take up to 45 minutes, depending on their level of comfort with technology. But it was a tremendous satisfier for the day of the appointment because we really didn't want our patients to become stressed about it working. We wanted them to focus on their time with a physician or a clinical person.
That's wonderful. And again, it's those investments then pay off because then they're able to come back and return to use it with frequency and consistency. That's great.
Right. Let me just also add with health equity. So organizations have been focused on health equity, but you have to understand where there are inequities before you can solve the problem. And so that's collecting data about patients. So we talked about the social determinants. We also talked about collecting that information through self-service portals became really important to us because we didn't know. So collecting race and ethnicity data and zip codes and whether or not people had other determinants, they live alone. And so we would create through portals the ability to collect that information that would then allow us to data mine and understand where we needed to focus. And sometimes that meant going out to communities, churches, sending out mobile vans to reach people. We also used technology during COVID for when the vaccines became available and COVID tests became available. We would send out public reminders to specific zip codes through that community's emergency telephone system.
Wow. And so when you do this outreach, by the way, sorry, I want to, this is a really interesting point. When you do outreach to communities and churches and you show up as Yale, what message are you coming with? I assume this is beyond just a vaccine drive, or is it specific to vaccines or something related to the COVID?
Well, we have done some things that are specific to chronic diseases, but specific to the vaccines, it's not, you don't just drive up in your mobile van. There has been a lot of education in communities where there was vaccine hesitancy or a lack of trust and agreement to get the vaccine. So there were several conversations beforehand, and then we set up a specific date and bring the mobile van out. But yeah, that's what was necessary.
Wow, fantastic. We've talked about a lot of things that are specific to COVID, the vaccine rollout, introduction of telemedicine. But I'm just wondering, for either of you, are there other examples of how your organizations have really learned to pivot during the pandemic? What have you discovered in your particular organizations and regions, maybe just beyond the examples that we've touched on so far?
Well, I'll just comment, Seth, that I think in many ways, it's allowed us to have our IT teams feel that much more connected to the mission of our organization. It's something that as a clinician, I've always tried to connect, the folks who are in the building off, away from the main hospital or the clinic setting, who are working on the bits and bytes to try and help them feel connected to what their work products are facilitating. And if anything, this whole experience has underscored for them, in particular because of a lot of these digital tools and virtual tools that we've enabled, to get a really strong connection to that mission and that sense of purpose around why we do what we come to work for every day. And that's been a strong motivator for our teams to continue to get them to work to release these things that frankly no one was planning on, and that we needed to pivot, be really quick with in rolling out. And that connection to the mission has been a really important thing for us and for our teams in particular.
Oh, that's great. And well, just above and Charlene, I'd love you to address as well. And you're getting to a question that was posted in the chat here on motivating and mobilizing your teams. When you take your IT team and you want to connect them more to the mission, what was one effective way of doing so? I mean, I assume you don't just sit down and say you're connected to the mission and here's the mission and you should feel connected. What's one way you bring them along and give them that sense of ownership?
So I would like 1 hour just to talk about this, just as one topic, because this is something really near and dear to my heart. So we start. So I'm glad whoever posed this question, you're like a plant out there. So we started a cultural transformation journey 2 years ago, and we brought in a company to help us create a customized, and I hate to call it a customer experience class because it's not just training. It was the start of a transformation where we brought in, or first of all, what we did was we identified people within our organization who do all of this extremely well. And it's what they do well is every interaction with the patient, helping them along the process, giving them a clear explanation of what they're asking them to do. And so what we did was we designed a course where we taught behaviors that people do things well. And no one comes to work wanting to not give a good experience to a patient. But what we did was we trained our team on small things to make every experience exceptional. And so this takes a lot of nurturing, the transformation that we went through. And so once we brought people in for a 2-hour training class, after that, we went through an entire year-long process of sustainability. And how do you keep it up? And how do you reinforce those behaviors? And how do you talk about what a really good experience has been? And so for us, this has been a couple of year journey, but motivating and mobilizing the troops has to be it was sort of a top down, this is who we are. This is how we interact and create great experiences for people. And that just sort of rolled into our digital journey as we started and continue this work.
Interesting. And you started by saying that you have so much energy on this topic. You spent an hour on it. Is it because you see this as such a pain point in your own organization, or that this connection was so absent pre-pandemic, or what? Tell us a little more about what's driving your energy around this topic.
Yeah. So it's interesting. So a lot of times you've got a problem and something's broken and you need to fix it. But this wasn't an area where we were broken. We were just hyperly focused on the digital experience and technology as a solution, or taking a look at our process and where is it broken in the process. Let's fix, either the process or the technology. And then we started to say, well, wait a minute, where's the people and human aspect of all of this? I don't even think we anticipated the response and the power we were going to see once we started talking about the people part of it. And so that just generated a whole bunch of energy, and the power was in the results of what we saw. And I would have employees come up to me and say, I just want to tell you that what we learned in this training class translated into my own personal life too. I had a problem with my child at school, and I just went through all of the lessons that you guys have taught me here, and it's just helped me everywhere.
Yeah. Dan, similar level of energy that Charlene's bringing to this topic. Do you agree?
Yeah, absolutely. This is it's such an important topic, and it's a little bit unfortunate that it took a pandemic to sort of underscore it for organizations, but it absolutely is. It's going to be the path for the future, as I alluded to right at the outset. These digital tools, this digital facilitation of people's healthcare experience is really the way that we're going to operate in the future. And so it's been, really refreshing for me to see how across the country, across the world, probably, these technologies have finally started to get the traction that they deserve, and that will ultimately help all of the patients and individuals that we serve, but will also help us within the healthcare environment to operate more efficiently and in a smoother way.
You each spoke of examples taking IT or non-clinical folks and connecting them more deeply to your mission, the overall care experience. What about the reverse during this time? Have you also had to work hard to make sure the clinicians are engaged and supportive of some of these IT transformations, or did people just immediately get it once telehealth spiked, or did you also have some work to do to bring them along?
No, we absolutely focus a lot, actually, internally on our care team members. All of these digital tools that we're talking about, they're not solely helping to facilitate things for our patients. They absolutely can help to improve the lives of our doctors, our nurses, every other care team provider in whatever function they serve. So, focusing on things like ambient clinical listening documentation, things that will allow our providers to do their clinical documentation using AI, not having to type, and so on. That's a huge one. Communication within a healthcare environment. We've still got pagers, we've got cell phones, we've got secure texting, we've got notes scribbled on pieces of paper. It's kind of chaotic for people that have got to respond to these multimodal ways of communication within a healthcare environment. And so thinking about ways that we can use these digital tools, and I'm not talking about like earth-shatteringly new technologies. These are commodities now that we've just not done a good job at implementing within healthcare. So I think attending to those needs is absolutely going to help to engage and improve lives for our provider teams.
Yeah. Charlene, do you have thoughts on this as well? Working with your clinical teams to get them engaged?
Yeah. So I have staff who sits at a front desk, and some of the phone calls that we get are for patients who need to refill their medication. And so if we can create an easy digital experience for that communication to go directly between patient and the caregiver who needs to be involved, or a pharmacy, and then it's also a way to preserve our resources, because we're not in a situation where we can just continuously add staff when volume increases, or we're just unable to do that. So we're trying to create solutions that will also be triggered through self-service to keep our costs under control, since resources and salaries are our biggest expense.
Yeah, for sure. That's great.
You did ask, Seth, I just want to mention too, you did ask for examples before.
Yeah.
On digital. I can think of another one which is related to radiology scheduling. For example, we would require patients to call us and say, I have an order from my physician for an MRI. And now we're looking at an electronic method for patients to have that order came through their EMR from the physician, and then have that patient schedule on his or her own and not requiring interaction. And so there's all these new ways that we're looking to increase our digital footprint so that patients can do more digitally.
That's great. And Dan, as I think about that question for you, I'm again coming back to the fact that you have such a rural population that have access challenges. Obviously, telemedicine is a huge advantage in those areas, but is there anything else that you can elaborate on with respect to your digital model for supporting those populations?
Yeah, absolutely, Seth. So first of all, on the telemedicine, virtual visit front, like most organizations nationwide, that just exploded. We were doing maybe 1,000 visits a month pre-pandemic, and then within a matter of a couple months, we were at 12,000 plus visits per month virtually, which is just mind-boggling.
Right.
So that's absolutely been a key staple in our technology portfolio that we're offering. But we also have been emphasizing a lot of care at home and utilizing remote patient monitoring approaches to be able to do that. And so again, we've got to be careful to make sure that the patients are facilitated in being able to do that. But there's companies that assist with this. So we partner with some organizations out there that can help you be able to either provide care completely for a patient in their home, avoiding a hospitalization or emergency room visit, that type of thing, or potentially even get them out of the hospital more quickly to allow them to recuperate at home. Again, using some of these remote monitoring approaches. So in some examples, post cardiac surgery, for example, we were able to send patients home with some monitoring devices that routinely measure blood pressure, weight, pulse, basic things like that. And those phone home at a regular interval and allow the team at the health system to be able to monitor those. And when you detect something not quite right with a particular patient, well, at that point, they pick up the phone and they say, hello, Mr. or Mrs. Jones, we detected something unusual in your data today. Tell us what's going on. And so we insert that human element back in. Again, some of the people who are a little bit more averse to the technology, you can facilitate that just through outreach, individualized outreach. And so that's been really effective for us. And again, we're going to continue to build on this, pandemic or not, because it's the right thing to do. It keeps people out of the hospital, which is ultimately what we want to do.
Yeah, it's such a win-win, right? Because consumers, a patient would prefer to be able to manage whatever their health issue is in the comfort of their own home. And it's obviously less costly and less burdensome for you all, right, to keep them out of the hospital.
Yeah, absolutely.
Sharlene, were you going to add a comment there? Or?
No, I was just agreeing.
Yeah. Well, and also you meant, Dan, you just said, which is a good segue to our next question, you just said, and this is something we're going to continue to build on post-pandemic. And so my next question, we all can think of, so many examples of things that we scrambled to put together during the pandemic. which of these, as you think about the different initiatives that your systems took on, what do you think are going to be Band-Aid solutions that ultimately will go away? And what do you think is here to stay? Are we going to forever use QR codes now? Was that a pandemic thing? So Charlene, do you want to go first here?
Sure. Yeah. So I think QR codes, that's funny, will be here to stay, whether or not we need them and there's something new that gets created. But until we have something new, which always happens, right? Someone creates something newer and better. It will be. And I think that I think there's a time and a place for interaction with a human being that's needed. So we should make access to our system easy for the patient, but it's not always easy. There's always something that goes wrong. And so you need to create that easy path. And then when that trigger happens for something to go wrong, then you easily revert the patient out and say, here's a phone number you can call. Seems like you're having some trouble here. Let me help you. So we just need to make it, something that makes sense, because if you think about you paying your bill for a patient who comes in to see a physician, or maybe just comes in for an emergency room visit or for a lab test, straightforward claim, single claim that goes out to a payer. The payer pays it correctly, and then there's a balance owed by the patient. Seems like it should be a really easy, simple experience, but there's a third party. If the patient has insurance, there's a third party that's involved in the process. So which just brings us to more places where there could be a failure in the system. And so, I don't know. I think that we just need to bring more awareness or transparency to the patient on the bill pay experience that I was giving and what's going on with the insurance company if they're involved in the payment, to make it easy.
Got it. So that's something that you would imagine continuing to do or building on from the start of the pandemic.
I think it's absolutely an opportunity that we can create a better process for our patient. We just need to bring all the right people to the table to solve it. Yeah.
Before we go to Dan, any Band-Aids, anything you think that we did that we're going to discard as soon as we can?
Oh, so what's interesting is the contactless experience. So we saw that through all of our interactions with people. I don't know what's going to happen. I don't know if that's a Band-Aid or not. So having chairs 6 feet apart, or having the patient not fill out any forms, certain interactions. Don't ever hand us your credit card because we don't want someone to touch it. I think some of that might be a Band-Aid.
Yeah. That makes sense. And I mean, Dan, you're the physician on this call, but also, especially, I think as we learned that the virus is airborne and not, transmitted surface to surface, there is a little bit of hygiene theater, I think, with some of these contactless approaches that we all have been,
Yeah, but you know what? Who knows what the next pandemic will include, and maybe the contact-free stuff is going to be relevant at that point. Yeah. So it may not be wasted effort. Who knows?
So Dan, what's your perspective on this?
Yeah, so I want to go back to some of the care at home stuff that we were talking about before. I only mentioned the acute care scenario or post-operative, that kind of thing. But I think there's also a really strong case to be made for patients with chronic conditions, and whether or not those encounters with providers always need to happen in a synchronous in-person way. I do think that there's a lot of interesting technology that's starting to be utilized more that can facilitate the management of many of those patients. So as an example, we were really fortunate to have received one of the HRSA evidence-based telehealth network grants, one of only 14 awards in the country. And ours was is focused on management of patients with diabetes in their home setting, using a mix of digital technologies, telehealth, e-consults, remote patient monitoring. And so this is a long-term grant, 5 years, to look at how we do this and whether or not it's effective or not. My gut tells me that this is going to work. My clinical experience as a pediatric endocrinologist managing a lot of patients with type 1 diabetes, I know that I didn't need to see those patients every 3 months in person. I could easily have done that with technology-enabled visits. And so that, is going to be a big satisfier for the patients, allow providers to be more efficient. And you know what, if we can maintain the same level of care for the patient or maybe even improve it, I think to your point from earlier, it's a win-win all around. And so I do think that the care at home models that we've put in place or energized with the result of COVID, I think those are definitely with us for the long haul. I think it goes without saying for telemedicine, virtual visits in general, that will certainly be with us. I also think some of the tools that were deployed that use AI, so some of the chat bots that you saw emerge around symptom checking and so on, I think there's a place for those as well in a non-pandemic environment. Thinking about trying to help people who are not sure whether they need to go into an emergency room visit or an urgent care visit. Could they be utilizing an AI-based solution on their smart devices or on the web that would allow them to run their symptoms by an algorithmic-based approach that could lead them? And there's several companies that are basing their business models on this now, and I do think there's something there. The AI has gotten that good, as long as it's backed up with real clinical folks who are ready to step in if and when the need arises. So I think those things are with us for the long haul as well.
It's analogous to what Sharlene was saying, right? Sharlene, you're saying there's always going to be situations on the financial side where a human needs to step in, maybe because insurance is creating some confusion or whatever it is. So these technology tools always need to be supported with folks in the background, it sounds like. Yeah. That's great. So you didn't mention, so neither had great Bandaid examples.
Oh, I forgot my Bandaid. Hang on. I do have one.
You do have one. Good. Okay.
Yeah. So we, states, health systems all over the country, pulled things out of the kitchen sink to set up immunization scheduling. That was done every which way, across the board, and it was chaotic. And I think a lot of the systems that got put in place around the country are not likely to survive, to the next round, whether it's boosters or who knows. So that was definitely a scramble. It did not go well in a lot of instances, and I think a lot of that technology will be lost in the shuffle, probably for good reason. The one thing that I'll use, though, that I think bears mentioning is just the fact that our public health infrastructure in this country, I think this has shown a light on the fact that we need to invest more in this overall. I mean, think about it. We each have a paper card that shows our immunization status. In 2021, that's what we had to rely on. And I don't think we can look ourselves in the mirror and say that was a good thing. And so I think stepping back, this will be a place that we absolutely need to invest more in as a country, and to get the states a bit more coordinated. I don't know whether this requires a federal intervention or at least to get the states to work together more. But it was an aha moment for a lot of people.
Yeah, for sure. Right. To digitize. I think the best that we were able to do is laminate the immunization card.
Yeah. That's great. Great examples. I fully agree with both. And I'm keeping my eye on the clock because I know we're going to be short on time soon. But one question, you both have talked about the importance of involving humans, even for our most sophisticated technology deployments. Dan, you gave an example on the clinical side, Sharlene on the administrative. Do you think there are any examples of digital experiences we've created today where that cannot be fully served by the technology themselves? Of course, humans need to kind of help cover where there's holes, right, or where there's problems that emerge. But overall, do you hear of any patients who say, and I really mean this on the administrative side, do you hear any patients say, oh, I don't want to engage with you digitally in this way. I prefer a human interaction when there's a digital alternative available? Does the question make sense?
Yeah. I think the only time it's going to be necessary, and again, maybe it falls into that, in the perfect scenario, all of the holes are aligned in the Swiss cheese. It's digital, but I'm thinking maybe if a patient can't get access to an appointment soon enough, then that's when they'll say, I'd rather really talk to a person because I don't trust that the system where you're showing me the appointments that are available is accurate. I think that a person has access to appointments that are sooner, if that makes sense.
Yes, it does. Yes, it does.
So I don't know that our patients would say it can't be digitized. I think that they may think that there's like some secret sauce that a person has.
Yeah. Dan,
and Seth, I'd add, look, there are some instances in which these digital approaches don't go right. Sharlene mentioned before, first impressions are lasting. And so if that first impression of that digital interaction didn't go well, they may not prefer to go that route in the future. And so in as many places as we've been able to, from a staffing perspective, we've tried to publish that phone number as well to say, if you're having trouble or if you prefer to contact us in person, don't hide it like the Amazons and every other digital company does. Make it public and make it visible, because there are going to be folks who just prefer that way. And so try and staff to that. Now, whether we'll continue to be able to do that in the future, as budgets become tighter and the drive to reduce healthcare expenditure continues to go downward, that remains to be seen. But for now, that's been successful for us, and we've definitely found patients that prefer that route.
Or maybe you'll be able to do it more if the digital avenues are servicing most of the mundane requests or predictable requests. Then maybe your teams will actually be freer to handle the acceptance.
And self-scheduling is a great example of that, right? For all of the thousands and thousands of patients that we schedule manually now, if 90% of those go away, then we'd have that much more bandwidth for those that need it.
Yeah. We can't underestimate, Dan, I think that you mentioned that you have a patient and family advisor group. We do too. We have over 100 patient and family advisors. We created a council just to look at our patient financial experience and the value of bringing people in and saying, does this piece of paper, does this form that we send out, does this process make sense to you? Where can we improve on this? It's so valuable because sometimes we don't even know the inner workings of our healthcare system, and what we think is happening isn't always reality. And so our patient and family advisors are very honest with us and tell us where we can improve. So just continuing to seek out feedback to who wants to give it to us and tell us where we're failing. I think it's our organization's responsibility to listen.
That's great. I'm trying to think about whether we go deeper here, but I think I should really move on to the last question in the fairness of time, which is, tell me about your digital wish list. What are you hopeful that you can invest in or bring your organizations to deploy further that's top of mind for you?
I guess I'll start, Seth. There's certainly some technologies, but first of all, let me ask for a wish list from the federal government maybe and or the states. So we need to get clarity around telemedicine and policies and payment. We want to continue the momentum that we achieved during COVID, but with so much uncertainty still in that landscape from a payment point of view, from a regulatory point of view, cross-state licensure, and all of the things that go along with that, reciprocity and so on. We need to get clarity there so that we're ready to invest further in it. But without it, there's some hesitation. And so I think that's an important one out of the gate.
It seems like Congress is the only entity that's...
I mentioned this digital momentum. Sorry, Seth, go ahead.
I was just adding, it seems like Congress is the only entity that's ambivalent still on the benefits of telemedicine.
So we'll see what happens. Hopefully they've drank the Kool-Aid as well, and we can get on with it. But I mentioned many of the other things. The digital momentum that we've gotten through the pandemic, I hope we don't lose that. We saw, Charlene mentioned before, how quickly we can move with these kinds of things when pressed into it. And so I would love to be able to achieve that same rate of change and adoption that we had during COVID.
Yeah.
I'm really focused on utilizing more AI-based technologies, as I mentioned. And so those are definitely on my wish list and focus list for the year. And then finally, not forgetting our clinicians. Again, as I mentioned before, this is not just externally facing. It's also got to be inward facing to our care teams.
That's great.
And the exhaustion and helping them recover from everything that has been taking away their time to really just focus on the patient. Yeah. So the only other thing that I can add to that wish list, and the payment side, reimbursement side, is extremely important, because we can't do what we do without making sure that we're securing payment for those services. And on the administrative side, within the revenue cycle, you have authorization requirements from insurance companies that are only growing in the number of services that require authorization, where you can perform a service. And then on the back end side, once the patient receives care and receives a bill, how transparent are the insurance companies and we with marrying up the EOB that you get from the insurance company and what the balance is that we're trying to collect from you? So just creating more transparency along the way. So if you think about that Amazon experience, you place your order, you get a notification. Thank you for placing your order. Here's where it is. Guess what? We put it on a truck and now it's being delivered to you. Oh, we delivered it to your house. We want to create that same transparency along the journey for the patient. Okay, you came in, you received, your claim was submitted to the insurance company. Here's the amount that was applied to the deductible, and just making the patient aware along the way so that at the end of the day, when they do get a bill, they're not saying, what is this for? I have no idea.
Right. And if you do those things, then they won't call you every 2 days wondering, is my, benefits apply? Is my insurance covering this? Like, where can I get my appointment? What's the set? Like, these are calls you absorb. So it's better to get ahead of them. Yeah, that's great. Well, those are good wish lists. Thank you both, and thank you. We can wrap at this point. Thank you both for joining us this afternoon and sharing your insights. It's remarkable the work that you're both leading in your leading health systems. And you have a ton to be proud of. So thank you for joining us, and thank you for your service.
Thank you for bringing us together.
That.
Yeah, and thank you to our audience for joining. I hope you found it useful, and we'll hopefully be in touch soon.